Good evening. I am Asia Mixon and I will be presenting my care plan. So my patient was a patient of the Department of Health. He presented originally on November 28th, 2018. He is a 43-year-old Asian male and he was following up on a recent diagnosis of his diabetes after he was seen at the emergency department with a glucose of 500. He was discharged from the ED with a prescription for metformin 500 milligrams to be taken twice a day. Since then, he has reported that he has not been checking his glucose levels regularly, but he also reported that he is no longer experiencing polyuria, polyphagia, or polydipsia. He has a past medical history of prediabetes, hyperlipidemia, HIV, and allergic rhinitis. He has no known allergies. He has a family history of his father who died of natural causes and a mother who had a history of kidney disease and actually died of kidney cancer. And he has occasional seasonal allergies. Labs that are included are considered to be pertinent labs to the case, such as his glucose upon his November 28th visit was decreased from 500 milligrams per deciliter to 296. He had an A1C of 13.6 and a weight of 140 pounds. And then his lipid levels were elevated. He had an LDL of 229, a total cholesterol of 308, and a total triglycerides of 105, and his HDL 56. And then at another visit more recently on July 31st of this year, his glucose levels were now 112. He had an A1C of 7%. His weight was slightly elevated. He had 146 pounds, and his blood pressure was 132/83. His current medications include Biktarvy, loratadine, pravastatin. He takes vitamin D3, metformin 500 twice a day, and Levemir 100 units per milliliter, which he injects 15 units subcutaneously with his evening meals. So my care plan. Overall, I felt my patient was pretty much stabilized once he got to his follow-up appointment back in July. So these are the changes that I decided to go with. With his metformin, I diagnosed his hyperglycemia as the primary problem. So our goals were to make sure he maintains his blood glucose levels within the ADA recommended guidelines because we want to prevent further complications, but we also want to make sure we prevent the occurrence of hypoglycemia. So as for my endpoints, I wanted to make sure he was counseled on the side effects of his medications. We educate him on the signs and symptoms of his hyper and hypoglycemia. We educate the patient on monitoring his glucose levels on the daily basis so he knows how his levels fluctuate so that he doesn't induce hypoglycemia if he doesn't need to take his insulin. We want to monitor his renal function, his blood glucose levels, his A1C, and his serum B12 levels. As far as my therapy recommendations, per the ADA guidelines, you want to start patients on metformin and keep them on metformin unless they come into a contraindication. The patient was started on 500 BID and you're supposed to increase it after about 2 weeks. However, this patient was able to fall within ADA recommended goals while being on the 500 milligrams. So I decided to keep him on his current diabetic regimen because it appears to be working for him. For his secondary problems, I listed hyperlipidemia and his weight loss. With his hyperlipidemia, his levels were elevated and his HDL levels were low. And so per the ACC AHA blood cholesterol guidelines, it recommends that you want to start the patient with a moderate intensity statin if they're between the ages of 40 to 75 and they also have diabetes. And I decided to discontinue low intensity and initiate a moderate intensity pravastatin 40 milligrams. So I tried to calculate the ASCVD score for this patient. Because he is of Asian descent, the website would not allow me to calculate a score for him because it said it did not want to overestimate or underestimate his risk levels. But I did find another website, MedCalc, that calculated his score, and I believe he only had a risk score of 6.7%. And I also decided to keep him on the pravastatin because since he is an HIV patient as well, I learned that most of the statins interact with HIV medication through the same pathway, so it could cause his HIV medication to either be induced or inhibited, and so that will alter his viral suppression and interfere with that therapy. Pravastatin is the preferred statin to be used in HIV patients, so that is why I decided to also keep him on it. As far as monitoring endpoints and monitoring parameters, we just want to make sure we counsel the patient on the side effects, watch for the muscle pain, anything like that. We want to educate him on what rhabdomyolysis is and how it appears, so he can alert his doctors or his pharmacist when he starts to experience those symptoms. We want to monitor his LFTs at baseline, again at 4 to 12 weeks, and then every 3 to 12 months after that, just to make sure there are no elevations. And with his weight loss, we want his BMI to be between 18.5 and 24.9. And I also feel like the weight loss would aid in improving his healthcare conditions. And so per the ADA guidelines in relation to diabetes, they encourage patients to engage in 150 minutes of moderate aerobic exercise. And they advise patients to lose between 5 to 7% of their total weight loss in efforts to control their diabetes levels. So with this, we're going to reassess the patient in about 3 months at his annual checkup, just to see how he is with his progress and see what barriers he's facing and help him overcome those. And we want to advise the patient to check his glucose levels before he starts working out, because if his levels are low and he begins working out, on top of that, that will just further decrease his levels. So he might want to eat a light snack just to kind of counteract that and not cause him to go into hypoglycemia. For his tertiary problems, I listed HIV and lifestyle modifications. With his HIV, he was able to achieve viral suppression, and so this will help aid in preventing the progression of AIDS and opportunistic infections. So I decided to keep him on his Biktarvy, the regimen that he's already on, because it is working for him, and you want to keep the patient on the regimen that is working, and continue his vitamin D supplements. Typically with these patients, they experience vitamin D deficiency, so that's why most doctors add on the vitamin D. And also per the HIV guidelines, it's recommended they do the INSTI with the 2 NNRTIs. They just want to counsel the patient on the side effects and the importance of medication adherence to make sure he continues his viral suppression. We're going to monitor LFTs, renal function, his CD4 count. You also want to follow up with this patient in 3 months. For his lifestyle modifications, I would recommend that we would assess the patient, his eating habits and his preferences to help develop a diet plan that works for him, so that he can find it easier to stick to without struggling and overcoming barriers. We want to reduce his intake of saturated and trans fat. He reduces caloric intake and his carbohydrate intake. I believe I saw in the notes that the doctor mentioned that he may want to decrease his intake of white rice, which is cultural for Asians. And we want to help him develop an effective meal plan that would best suit his life. So to reinforce that, you just counsel the patient on healthy eating, why it's important, what it can do for him, how it can help him even eventually get off some of his medications once he returns to normal, or less medications once he gets under control. And you want to advise the patient to seek support from loved ones to aid him in his efforts, so that he doesn't feel like he's alone, that he's going on his own. These are my references. Are there any questions?